So I'll proceed with the case straight away. So the short history for this patient is it's a 33-year-old male again, seeking on hemodialysis. He has been on the wait list for around 3 years. Right now, the access is a right radiocephalic AV fistula. He had a failed AV fistula on the left hand in 2024. And this is his status post of fistuloplasty. And he has also undergone central venoplasty. So that's a troublesome access that we have. In 2023, he was admitted with a pneumonia. Did not do anything. There was nothing great. And the only significant history is that the mother had donated a kidney in April 2022. With that background, so this is the recipient's HLA. I hope you can see some of that. Yeah. Okay. So he gets a deceased donor call, 29/8/25. So that's like 2 months, 1.5 months back. 19-year-old male, head injury, and then creatinine of 0.84. The heart was donated, and hence we got the HLA from a different institute. So a different center did the HLA and gave it to us. So this is the donor's HLA, and this was done by SSOP. But we have limited data on that. Our usual protocol is to do a B, C, DR others, DQ-A1 and DQ-B1. But what we got was only A, B, DR, and C, and DQ-B1. So we have an abbreviated HLA, and there are a lot of mismatches. The mismatches are in red. Okay. So this was the SAB that was done luckily just a little while ago, just 3 months back. So this was around this. If you see, this is the donor's HLA again. This is the recipient's HLA, and the last two columns are the donor's HLA, and the mismatches are highlighted. So A, luckily there is nothing. But for B we have two, B4006 and B4001. The common issue with us, this is a very common scenario we saw in the last immunology workshop, that it's around 30% of our population that has a B4006, and this was the situation. So we have two beads in these SAB kit. They are like, this is the Werfen kit that we usually use. So it's a 4001 and a 4002, and they are placed at 4000 and 2668. So how often do we face something like this? I'll get there. Okay, this was lower down. So 5001 bead was actually negative. Look at the class 2 beads. Again, this is the HLA. So we have 1502, 1501, and 1503. All three beads are positive, and they are at a MFI of around 2000. So how do you interpret that? What is the policy? How to interpret this? Would you want to add them together, call it a 6000, or would you think of it as a dominant DSA being around 2300 and then go ahead with the transplant? What would you do? Like, while just the interpretation of these, because this is a very common scenario where we have multiple beads of the same locus and they're like spread across all these beads. Any inputs from the audience, please, or the panel? This kind of scenario, because these are DSS on the serology. If you see, they are all 15. They are 15. Or would you want a?
Okay, I mean, I think center to center is different practice, but I personally don't do a cumulative this thing. But irrespective of it, I will take it as a DSA. Like it's a genuine DSA.
But see, if you add them together, our usual cutoff is around 3000.
If I have how much is the MFI?
So 2300.
Okay, 2000 MFI is something for a DR.
But if you add them together, that becomes 6000.
Yeah.
So
but
that's
still it's a
cultural
DSA.
crossmatch positive.
Still it's a DSA.
But theoretically, what we're thinking is these are antibodies which may be against that shared epitope on those beads.
It is a single molecule. This is a single molecule. You have to look at 2167.
No. Actually, Subha's question is that how much
epitope,
MFI you attribute it to?
How much he's saying that there might be shared epitopes, hence he's adding everything. So I would say, look at the molecule, see if there is really any shared epitope which you think is giving that MFI.
When the serology is DR15, so not at a time when we did not recognize 1501, 1502, 1503, they were all reacting to the same thing.
Dr. Subha, serology nomenclature is very old. So these were previously known as DR15, but at the moment, because the
For a
sequences are
cause,
different,
for a cause,
so
isn't it?
the
Like my understanding is, if they were called DR15 at a time, they would have a similar reactivity.
no,
Then
but
we
those
found out that
no. There are certain common sequences, but there are certain unique sequences. So we need to compare the sequence of 1501 versus 1502 and 1503. Only if there is a particular epitope that is common, then only we might be able to say, okay, then. Otherwise, 1502, and if you know the donor typing, we can simply say this is the DSA.
So telling for really the DSA, you should also understand this allele plus protein. So 15, 02, 01 and 03 separately. And you cannot say if antibody against 1502, that would be similar to 1501.
Yeah.
So that is the current understanding. And that also every industry manufacturers, everyone gives the similar kind of the instructions.
All the beats are actually individually.
It is quite possible might be the
different, so you cannot
sharing, but
add
you have
them
to do
up.
the
Like
different
if
things.
the,
Only-
even if it is a shared epitope, the antibodies are against that, but then that bit is put separately, the second bit is put separately. So the antibodies in 1 plus 2 plus 3, we
But
cannot add that.
as long as you know the donor HLA type, and you know, even if there is a shared epitope, but if that is not between the 1502, the antibody will not bind.
Madam, let me be devil's advocate. Suppose you have a donor coming in and you just have a serological typing. Okay. So will you take it as a, no, just imagine, hypothetical situation. That's what, so will you take it as a 6,000 or a 2,000? Am I right?
yeah, correct.
That is the question.
So if you, so
But now with the current understanding, we have talked to industry persons. Yeah. Now we have to take individually. If you have a high resolution
I think you
typing
guys,
is important.
you're adding, right? You would add?
Not unless if it is
There are no serology kits available, so you will never get a serology typing, so you'll never get confused.
Dr. Subo, we have to understand that the protein which is coded by 1502 is different from a protein coded by 1501. So there can be an antibody which may bind to both. It can be a possibility, but actually these two are different proteins. 1502, 1501 and 1503. They will be different proteins.
Yeah, very true, very true.
So it may happen that they may share an epitope. That you'll have to see, but you can't sum up them. You can't make it 6,000. It is 2,000, whatever figure.
Even with 2000 MFI, you will definitely be doing something. I mean, you're not going to ignore 2000 MFI just like that. So
Yeah, so our cutoff. So we use that
What's your
concept of
cutoff?
immunodominant bead.
So how
So
do you-
what? So
how do you decide the
we think of
cutoff?
this as 2320. That's it. We
Yeah.
ignore the other beads.
yes, that's
We
true.
ignore the other beads.
Absolutely
Okay.
fine.
But like theoretically, what I think is there is a antigen which has now we have gone into the various details, but on the whole, this is a DR15. So it will react to a DR15
The
sera.
protein structure is going to be different. This
So-
is why the protein structure on the cell surface is going to be different.
So,
the epitope
I
may
think,
not be.
can you go ahead basically? So
Yeah,
we
I
are
think
short of
so.
time.
So our concept is to use the immunodominant sera only, immunodominant number only. So it's 2300. So okay, and again DR345 was not typed, so we didn't get the DR345 typing. No.
Was there a role of doing an applet?
Yeah,
in this?
definitely. So this kind of query can actually be solved by doing the epitope analysis, and we don't need to do much. We just need to get those results. You see the last column. The typing actually provides you with a lot of that usable information. So right. So this has already been covered as to what the typical cutoffs would be, and we did a reverse counting for this. Like how do you do that? So DRB1, the patient is DRB1, so that should be a null, and DRB15 is associated with DRB5. So that's luckily there are no antibodies. So we call that a virtual cutoff negative. This was also 2300. So our cutoff for a disease owner is around 3000, provided the flow is negative. So we don't do a CDC usually. So it was not done as per central policy because it takes a lot of time. So we did a flow cross match, and both were negative. So this is a short summary. We have this patient, and now there is no B4006 bead. The cutoff, we have the 2668 kind of number in the B4202, and DR15 beads multiple are positive, but the cutoff is around 2300. So we have a patient with little bit of class 1 and class 1 and little bit of class 2 antibodies. Both of us are that is below, and the cross match is negative. So we don't want to accept this offer. So in like. So I think it will depend upon your center's policy of acceptance of the virtual cross match. At what level would you call it a virtual cross match positive? But with the cross matches negative, so we did think of progressive. But before that, so I'll skip all of that. So we interpreted the 4006 as the 4002. So where all of these antibodies come from? What is the sensation history? I've told you that. So the mother was the donor. So this was the mother's HLA, right? So we have all of that positive. And he did actually have a unit of blood transfusion. This was in 2022 when he got the first transplant. This was the standard induction that was given. And I mean, we have covered that in the first session only. We'll just go back. So he was discharged uneventfully on post-op day 6. And then acute event happened, renal vein thrombosis. The patient went back to dialysis just after 1 month of dialysis, 1 month of transplant, and the failed graft is still in situ. And we did a workup for the hypercoagulable state, and the protein C, protein S, they were low at 0 and 4 months. In 2023, when he developed that pneumonia, the tacrolimus was also omitted, and he continued to be on prednisolone 5 mg per day. So now let us look at the old records. So if you remember, our donor is 4006, right? So the 4002 bead showed a 12,000 MFI. So this is the importance of doing the repeated number of repeated SABs. So 4003, so 4002 was around 12,000, and 1502 that was around 13,500. So these were impressive MFIs to start with. So historically, we have strong DSAs. So that is what we were talking about in the last case also. Now coming down, that was in 2023. This is 2024. So the 4002 beat, the MFIs, they have died down to around 5,000, and the 1502 was 2,700. So it has been coming down from that 12,000 and 13,000 numbers, and coming down now. Coming back to this offer, so now we have a repeat mismatch. This has been always talked about, repeat mismatch at 4006. The first donor had a 4006, the second donor had a 4006, and we have small MFI around 2,300 of antibodies to this. And we know that historically the antibodies have been higher. They have been around 12,000 for the B4006, and for 1502 it has been around 13,000. So would you want to still accept the offer?
Why did you consider 4006 to be a positive mismatch when you didn't have that beat?
Yeah, so the way to work around that is what we were discussing in the morning, is that the 40s, see, how do the companies make the panels? They will check all the epitopes that are being given. So to just with 100 beats, you can cover a lot of area. So they strategically place some of those beats because of the antigenic sharing and everything. So it may or may not be absolutely representative, but if you have to call it one way or the other, it is a surrogate to use one of the other beats. Exactly.
But I don't think that is the case.
Yeah, so that is.
This is probably a memory response to a previous historical positive DSA. Even though there was significant DSA in history, historically, which was a memory cell which must have caused this graft vein thrombosis, not immediately recent after post-transplant.
That was the first transplant. That was a naive patient.
This after discharge, you said the patient had.
No, that was the first transplant. That was the 2022 transplant. The patient received a kidney from the mother, and then there was a graft loss. And subsequently, we have been doing all these SABs, so around 6-month gaps. So I've showed you some of them reports. So initially it was around 3,000, came down to around 5,000-ish. Now at the presentation, they are around 2,000. The question is, would you want to accept such a offer where we have the evidence of a repeat mismatch?
You might still have those memory cells, and once you transplant with this donor, there's a possibility that again the antibody titers go up.
Yeah.
So maybe
But even if it's historically positive, I think you've got a case where the flow is negative but single antigen beat positive. So you've got a positive DSA but flow negative. So it's not high enough. I mean, I would certainly be cautious given a repeat mismatch and a current positive DSA with historically high levels. But although your flow is negative, but you still have a DSA.
Sir, I think you cannot accept this because there will be a memory response. You had a historic DSA of B4006 with a high MFI of 12,050. And now if you accept this offer, I think the memory response you'll land up in another rejection because 4006 also shares an epitope with B400102, whatever is there here.
What is
And
it?
even DR15 also 02, 01, 03, they all share the same applet. So you will again land up in the rejection with a memory response.
I think you should have done a CDC
Yeah.
work. Doing CDC would help you to see whether that's functional or not. At least that's a complement binding antibody or not. So without CDC, you are doing just a flow. Flow is a binding assay. CDC would.
Our experience with flow is like if you do a flow, you find it negative. I mean, it's
Especially when you are seeing an antibody.
very unusual to find a CDC positive and a flow negative.
No.
Yeah.
A quick comment. The MFI is on a logarithmic scale. Adding two
Very important.
MFIs gives you a meaningless number. So I don't think you should be doing it. So that's all comment I want to make.
Thank you.
Right. Okay. So usually, what is your make or break test? Would you look at the DSAs? Would you look at the history, or would you look at the flow? And like, what would you do? This is mind you a failing access. A patient who has been waiting for more than 3 years. Would you be tempted to take this offer? Kind of.
I mean, I think, as we said earlier, we need to find a graph that actually lasts him, low
very true.
immunological
This is a
risk. And he's young,
guy,
obviously.
yeah,
So we need to bear that in mind. And second is, I think the source of the antibody is equally important. If it was blood transfusion, I don't think, anyone would actually be so concerned. But if it's a repeat mismatch, then certainly I would be cautious.
Yeah, totally.
Yeah, very true. Very true. No, second only.
Well, I guess if the patient is going to die in a few months because of access failure, then you may want to take that risk, though, isn't it? It all
Yeah,
depends
so-
what you're losing. Are you losing with rejection, or are you going to lose your patient? So you might stuck with immunology sort out and miss out your patient. So I don't know, what did you do? Doesn't
No, this
matter.
is disease
If
owner.
the patient is dying,
This is disease owner.
I don't think it matters really live or deceased. If the patient is going to die,
So I think we got brave, and I think we got actually too brave. That is what was proven in the subsequent days. So we did actually do a transplant. We were kind of afraid, but the guy was very insistent, and I have to admit that the kind of data that we had at the time of the transplant at 3 o'clock in the night was not this detailed. We had some missing points. I think we should have done better than that. So we thought there are some antibodies. Let us do that. We had one of those that 5,000 was available to us. But with the cross match negative and this dying access and everything, so we thought we'll just do. Our plan was to give him ATG up to 3 milligram per kg, and if need be more, we started him on IVIG, and we reached a dose of around 2.86 by day 2. Now, since he had this history of graft vein thrombosis, we put him on dalteparin, and subsequently, this is what happened. So if you look at the first few days, up to 3.39, he was doing relatively fine. Then he developed a little bit of fever. So the graph just jumped to 3.8. We were like, what's happening? Should we do a biopsy? Should we go for plasmapheresis or something? So next day it was 5.14. Huge jump. And we did a biopsy then and there. Yeah, obviously. So fever cough. So tacrolimus level was around 5.6. Further, so biopsy was planned on day 8. So dalteparin was omitted. There was a little post biopsy collection. So around 120 ml or something. So we did not give the dalteparin back again. So the biopsy was reported next day provisionally, G2, P2, PTC2, C4D3. So intense rejection there. So we started plasmapheresis. So this is the
30
jump that
seconds.
happened. So
30 seconds more.
Yeah, so 4002 became from 2500 became 21,000, and DR15 became 16,000. So huge jump. We now know what has happened. So continued with plasmapheresis, the urine output decreased to 50 ml per day. Absolute shutdown. And the graft, because of the plasmapheresis, probably the collection increased to around 280, still not on dalteparin. So developed a little bit of fever. We thought maybe injection rejection related. The collection was increasing. We still continued to do the plaques, but we did not start dalteparin. Why? Because we have done a biopsy. It's kind of risky, and then there's a collection, and we are doing plasmapheresis, and then to add dalteparin onto that
10
would be like a little
seconds.
too much.
Yeah.
Day 17, graft failure. So because of thrombosis. So one of our thoughts is probably an intense rejection can cause a very poor flow to the graft because of the graft swelling and everything, and that can be one of the causes of the DVT. Discharge on day 37 with both grafts in situ, nearly anuric, clinically stable, still on dialysis, is back, going for a graft nephrectomy today. So what are the lessons learned? Retransplant has complex immunology. You have to have all your data together. So repeat mismatches need to be avoided. Policy on class 1 and class 2, both antibodies. So maybe that kind of situation, you might want to be like double sure. Now this subset has very bad outcomes that has been shown in multiple papers. So we should not have accepted this repeat mismatch. Maybe we could have gone
I'm
with
extremely
preemptive
sorry
dialysis.
to intervene
Yeah.
here, sir. We have
And
other
be watchful in
speakers
patients who
waiting.
have developed previous vascular catastrophes. Thank you.
Thank you very much.